Parathyroid puzzle. Disentangling primary and secondary hyperparathyroidism in kidney transplant recipient. This case is about a 63-year-old male with hypertension, hyperlipidemia, uncontrolled diabetes type 2, and chronic kidney disease stage 5, who was evaluated in clinic 6 months status post a kidney transplant. Prior to the transplant, the patient had a normal serum calcium and elevated PTH, features of secondary hyperparathyroidism. However, 6 months post the transplant, the calcium was found to be elevated at 12.4, and PTH almost doubled from prior to the transplant at 370. The patient had been complaining of constipation, so a decision was made to further investigate this new onset hypercalcemia in the setting of these findings. On neck ultrasound, a large inferior parathyroid gland was noted. Further imaging was pursued, and the patient underwent a technetium-99 cystoscopy scan showing a persistent mild radiotransfer activity at the inferior aspect of the left thyroid. On SPECT-CT, this imaging corresponded to a 1.4 centimeter soft tissue nodular lesion, inferior medial and separate to the left thyroid lobe, suspicious for a hyperfunctioning parathyroid adenoma. With severe chronic kidney disease comes hyperphosphatemia and low vitamin D levels, which lead to a progressive secondary hyperparathyroidism and parathyroid hyperplasia. After a kidney transplant, there is an expected improvement of these abnormalities, which is incremental in time. A long-term study following 1,000 transplant patients reported almost 17% of these patients were hypercalcemic at 12 months post-transplant, and nearly 48 had elevated PTH. Despite this, there is a subset of patients that, due to long-standing secondary hyperparathyroidism, diffuse hyperplasia of the parathyroid can occur. In some patients, as we can see, nodular hyperplasia can develop, and they can exhibit characteristics of autonomous adenomas as seen in primary hyperparathyroidism, where we can find elevated PTH levels and hypercalcemia. There are usually no overt physical findings of post-transplant hyperparathyroidism, and this is usually discovered by laboratory testing. Persistent post-transplant hyperparathyroidism has been associated with increased risk of bone fractures, increased mortality, and decreased allograft survival. Knowing this, it is our goal for post-transplant patients to obtain appropriate levels of PTH, calcium, and phosphate, either with conservative therapy or parathyroidectomy if needed, within a timely manner. In conclusion, secondary hyperparathyroidism is common upon most kidney transplant patients due to diffuse hyperplasia. However, we must not forget that adenomas may develop. These must be closely monitored, and we should not delay treatment. Thank you for listening.